And welcome back to week 7 of ST 710 exam prep. We're entering in the home stretch, y'all. This week is all about sharpening our skills and revisiting two crucial surgical areas. We're going to make sure that we keep our resources in mind. Week 7 is really trying to kind of like hone in on different things. Now, for our agenda, as promised, I did go back to the questions that were asked and got a little information for y'all to kind of help tie everything together. We have our quote of the week as per usual. And our focus is on reconstructive surgery, head and neck surgery. So we're going to, of course, touch on that. With that, we do have to look at different principles of constructive and cosmetic procedures. We're going to look at some surgical cases, and then I created some charts to kind of help break down asepsis and sterilization as our mock 2 focus, and then we're going to wrap it all up. Okay. With that, I know other individuals are still joining us, but this week we're going to keep this thought from Charles Ernst in our mind. Okay. The details are not the details, they make the design. Now, in surgery, and in your CST exam prep, the mock, and of course, ultimately the CST exam, the small things are everything. Knowing exactly where an instrument is placed, understanding the layers of tissues, recognizing the small, subtle steps of a procedure. These small details are what really create patient safety, surgical success, and of course, your professional excellence. But I'm not going to lie, it is so easy to feel overwhelmed by all the little things that, of course, you have to remember. But those details are not extra work, believe it or not. They are the work. They are what sets apart a good surgical tech from a great one. Master the details, and you will master the whole craft. I encourage you to keep learning. Use flashcards, even checklists. I'm trying to constantly like give you guys little different things to put into your toolbox. Why? Because every practice session matters more than you will actually know. Even if it's just 1 minute that you're driving and you're thinking of, okay, I did this cool cataract surgery. Let me think of the instruments that were used. Even that quickness is helping with muscle memory. Now, your attention to detail is building the kind of certified surgical technologists the OR team dreams of having by their side. So the details are not the details, they make the design. All right. So last week we had some questions, some different topics that you guys wanted just a little bit more on. And so did some little things just to kind of make sure that, you know, we are touching on those. With that, at the end of today, if you guys still have different questions or maybe something I didn't touch on, we'll go over it. I will do my thing and then present it again in the beginning of what next week, which is, believe it or not, week 8. So we had some accept questions, okay? We know they're a little bit confusing. They require careful reading. We know that another one of the concerns was some instruments and topics appear that were not necessarily covered in previous modules. You guys still wanted a little bit more on pharmacology, still processing, ophthalmic eye instruments, medications, especially questions involving contraindications. I looked up Fiducia retractor and we're going to go over what I found. We're going to start off with lumens and instruments. And I got a little clip of an oscillating saw that is used during surgery. So, as Kevin Hart says, it's about to go down. Right off the bat, we look at lumens. Okay. Now, we talk about just the definition. A lumen is the inside space or channel of a tubular structure. Okay. That's what a lumen is. The cool thing is it can be inside a surgical instrument like suction tip, trocars, cannulas, a body structure like a blood vessel or an intestines, and then tubing, as you guys can see, Foley catheters, suction lines, etc. Now, one of the best ways is to kind of figure out why it matters in the operating room. Well, we look at different topics, and I'm going to send you guys this, but I wanted to kind of have it here for mod 6 if they're here, so they can kind of take a screenshot. Of course, you guys are going to get it in the archive area. So we look at lumen instruments. Okay, they've got to be flushed, dried before sterilization. That may require longer exposure time. I have seen questions where they'll ask, if you have a lumen, the exposure time has to be, and they'll give you some different times: 1 minute, 2 minute, 5 minutes, 10 minutes. With a lumen, it's going to always be 10 minutes because we want it to be a little bit longer. When we talk about a blocked lumen, one of the things that we have to make sure that we're doing interoperatively is clearing it out. So like if you've done a lot of tympanomastoids or just mastoids in general, or any type of case where you have a suction, especially when we're going in a smaller area, one thing that I tend to do is I have another suction with a smaller Fraser tip, and I'm constantly cleaning out because they do get clogged quite frequently. So even at the sterile field, I'm cleaning out my lumens. It doesn't matter if I have like 14 French, 18 French, if I'm using a Yankar, because sometimes the Yankars, depending on like my bigger ortho cases, I'm gonna be trying to flush those out. We are always, always, always checking lumens for debris. So the biggest way to remember this, and I know many of you may not have done ortho yet, but if you have a drill, believe it or not, there is a lumen in the drill, because a lot of times we're going to use Kirschner wires or a K wire before we drill. So they'll place the K wire, then they'll drill over the K wire. Well, one of the first things that I do is I grab a K wire, and if I have drill bits or a lumen drill, I'm going to constantly go through with a K-wire and just make sure that every drill, doesn't matter if I'm going to use it or not, is free of bioburden. I have had cases where I started opening, and indeed there was bioburden where I had to get a whole new entire set. Okay, so we're also looking for cracks or moisture in our packages themselves before we use it. And then I wanted to add just some of the equipment. So Fraser suction tips, pool suction tips, even your Varus needles. Of course, your trocar cannulas. These are going to be more of your reusable ones. So your arthroscopy ones, because those are reprocessed. When it comes to general, not saying it can't happen, but it's going to be a little bit harder because those are usually disposable. But anything that has a opening. And so even though the lumen that I showed you was of a vessel, right? Just to show you that it's an opening, okay? And so again, you guys are going to get this and why it's relevant for the CST exam. All right, now for my 600s, make sure you guys take a screenshot so that you will have the exact same information. So how do we connect it to real life? Okay, well, before sterilizing the Fraser suction, actually any suction that's going to be reprocessed, we flush it with sterile water. Again, we're checking for bioburden, debris, and then you want it to be completely dry. We also look at trocars that won't fit the camera. What's wrong? Let's say you are using a 30-degree scope, 10 millimeter, 30-degree scope, but all your trocars are 5 millimeters. That's not going to fit, right? So 9 times out of 10, you got to make sure that you do have a 10 or 11 trocar to be able to fit that camera. Okay, so that's another thing that we look at. But if it's obstructed or the wrong size cannula was selected, what do we do? Well, we grab the correct cannula. Nothing crazy. A lot of times a surgeon may request a catheter with a larger lumen. Why do you guys think that is? Why would a surgeon, like let's say on their preference card, they have one size lumen. we get into the case, and now they're asking for a larger lumen. Why might that be? What do you guys think? Think about those cases where they had a size up on their field, they tried it, and then they asked for a larger size. I'm trying to think of a case where we would even have to switch. You're doing a laparotomy, okay? You have a trocar for your camera, maybe 110, two fives, and as they get ready to take out the appendectomy or the appendix, going from MIS to open, that could be one. I can see it. But more specifically, we're going to stay laparoscopically for lap appy or inguinal hernia. Those are the correct cases. That's correct. Has there ever been a time where we've had to move the camera? There we go. More power. You need a suction, more irrigation. Okay, so you're trying to improve the flow, allowing suction or thicker material. You may even have a rupture. These are going to be some reasons why you may need a larger catheter with a larger lumen. Remember, the lumen is just the opening. Okay, does that break down lumens? And let me see if Nareen is here because I know that was her question. I don't see her
Yes,
yet.
I'm here.
Okay, I was looking for your name. Okay, perfect. So, okay, perfect. I just wanted to kind of break down the looming because that was one of the questions, but we're not done yet. The next thing okay, there you guys see. The next thing is how does this relate to CST questions? Granted, I'm not going to grab the exact CST question, but questions that will mirror what you may see on this next mock 3. Keep in mind, mock 1 focused on certain kind of questions, mock 2 focused on a different type of questions, and of course, mock 3, another that we're going to see. But here's a question. Of course, we have the correct answer. We know that's pool. But during instrument processing, the CST identifies several items with lumens. Remember, those just have holes. Um, which of the following requires special consideration before steam sterilization? Now, we look at METs, cryo, and Army Navy retractors. And then we have a pull suction. Only one of these has a lumen. It does have two pieces. That is correct. The other thing that we have, yes, you guys are on it. Separate the parts. You're checking for bioburden. You're flushing them out, right? You're flushing these, making sure that whatever this pull suction, sometimes they use the guard, sometimes they don't. Whatever was in there doesn't get carried on to the next patient. Okay. This is why we have to flush out these lumens before they're dried. Because you got to remember, right after the surgical case, it's almost like if you were a cooker, like if you cook a lot, or if you even bake, if you wait for the batter to harden, it's a little bit harder to get off versus right after the surgical case. Everything's still kind of fresh. I know that sounds kind of weird, morbid, but it's still kind of fresh. It's easier to get whatever was in there out. Okay. Or sometimes it's the Pycon, Andrew, is two pieces from the tip of the suction tip. Also, if you have a Yankar with tip, like if you're using the metal one, the metal piece, we still separate that and clean that as well. So kind of think of it that way. Okay. Now, here's another one. The surgeon is preparing to insert a Verus needle at the beginning of a laparoscopic procedure. The CST should verify that we have a couple choices and we see that it's A, the lumen is patent and unobstructed. This is important. What happens if we hook up the Verus needle to the insufflation tubing and nothing happens? Keep in mind, if you can't see what's going on, the surgeon can't see. The Verus needle has to be clear because that CO2 is needed to insufflate or, expand the belly so that the surgeon can kind of see. Okay. So that's another thing. You also want to make sure that you have the right lever open or close. So like when you hook up the insufflation tubing, you want to make sure that it's not just open and it's coming out and nothing's inflating, right? Something can be stuck in the lumen or the gas could potentially not be connected. That's all correct. Okay. Now, the other thing that I had is some little study tips. Okay. We look at the instrument item, Fraser, Veris needle, trocar, hemostat. Right off the bat, one of these is not like the other, right? So we know the hemostat going to be process of elimination. So then we look at which one has lumens, Fraser, Veris, and trocar. Boom, we know that. And then I wanted you guys to kind of see what to check for. So your Fraser, you want to flush it, make sure it's dry. For Veris needle, it's clear for gas. For trocar, it's fit and patency. This also can kind of help guide you as to where these are going to be used, right? So your Fraser tip, we could be sucking out anything. We could have a Fraser tip in the ear, right? We could have a Fraser tip where we're using dental, oral maxillofacial. We could be doing a smaller microscopic case where the surgeon requests this particular suction. For the Veris needle, it makes sense why we have to clear it for gas. Why would we have to clear this Veris needle for gas? Like, what are we using the Veris needle for? Right. So then we're like, this is going to be for some type of laparoscopic case because that's the only reason why we would have to clear out the gas. And then trocars, we're making sure that if we have a 5 millimeter trocar, make sure that that surgeon is going to use a 5 millimeter scope that can go into that trocar. Otherwise, if you have a 1030, a 10-0, it's not going to fit. Okay. Does that make sense? Okay. All right. Now, an instrument that I looked up Fukuda test, you guys, a lot. I was searching because I was like, okay. Now, the Fukuda test is not actually a retractor, it's an actual thing. But it's close, it's a neurological balance test. So it's not necessarily related to retractors. Okay. Um, yeah, so it's the Fukuda test. It's for neurological balance. The only other instrument that I was searching for that I was like kind of close to it. Yes, Fukuda test is not an instrument, but the Finochetti retractor is the only thing that I could find. It's used to spread during chest surgery. Okay. It's common when we're doing open heart procedures or lung procedures. And it was the one that I was like, well, this is kind of close, and I'm not sure how many people have seen this particular instrument. So I will still do some more if this wasn't related to the question that you guys had. Yes, Naireen, I see your hand is raised.
Yes, my question was regarding the suction tips, or in general, everything has lumen.
Mhm.
We learned that we have to flush them before sterilization
Yes.
and keep some water, distilled water in the lumen, because it's harder for the steam to get in there. So we leave some water to heat and create a steam inside the lumen. But here I see you say flush and dry, and the question before that was saying dry it, or
Hmm.
the slide before that was says
Hold on, let me go back again. Let me
which
go back
one?
again.
Yeah,
Flush with still
flush.
water, check for debris, and dry completely. So you still do your step, but this is going to be before you get to that step because we've got to make sure that there's nothing in there first. Okay, so we're going to flush it, we're going to try to dry it, and then we do your step where you were saying. So it's kind of like in progression, if that makes sense. So that's correct, but we still not now keep in mind, not every facility is going to take the time to do the whole thing, right?
Yeah.
But per the book, we flush with sterile water, we check for debris, we let it dry, and then we go to the next step in the process of sterilization. Does that make sense?
Oh, yeah. I mean, what I get is this part is the decontamination
Mhm.
process. Then when
Before we get to your part.
before putting into sterilizer,
Yes.
we put water in the lumen, if
Yes.
I'm getting it correctly.
So steps in progression. But yes, you're right on track.
Okay. Thank
But that
you.
doesn't mean that what we do in the real world, right? Where we separate. Yeah. So just keep that in mind. Okay.
Thank you.
You're welcome. Okay, let's see. We here. Okay. So again, when I was searching, this is what I came up, or this is what I saw, the neurological balance test. Okay. Again, if this is not the right thing you guys were talking about, just let me know. I will do some more research to kind of figure out exactly what instrument you guys were like looking at. But the closest I could find is the Finochetta rib retractor or the rib spreader, and is exactly what that means. When we're sawing down, we use that to open up or spread the ribs open so that we can get to the heart or the lungs. Okay. So if you haven't done a lot of heart cases or even lung cases, you may not have seen this particular retractor. The other thing um, is this. So medications and contraindications was one thing you guys were talking about. And so with the help of ChatGPT, I was like, I need to make this chart. So I grabbed a couple medications. I wanted to make it nice and neat so that you guys could have it as just something to kind of look over with it over um, the medication name, what it's used for, contraindicated in, let's say, for fingers, for bleeding, arterial blood supply, and then the reason. Okay, so like with epinephrine, with the digits, you don't want the digits to die, right? So that's one of the biggest things. Heparin. We got to remember heparin's already an anticoagulant. So we use it in vascular cases. So if it's an anticoagulant, we do not want the patient to bleed more. So this is why we would not give it for active bleeding or somebody with hemorrhagic stroke because their body's already kind of like bleeding. Okay. Lidocaine with epi, it's a local anesthesia. It's contraindicated in areas with in arterial blood supply. So again, digits, same as epinephrine. Okay. Your digits can unfortunately become ischemia or necrotic and die. Okay. Steroids reduces inflammation. This is what we're giving it for. Prevent swelling. But if patient has uncontrolled diabetes or systematic infection, we're not going to give it because remember their immune system is already compromised. So you don't want to do something that's going to raise their blood sugar. They have diabetes, the insulin production is not what it needs to be. So, you give them something that's going to give them more sugar, they can go into a diabetic coma, right? Nitrous oxide, which is just gas, bowel or ear surgery, where air filled cavities are present because it will expand the air pockets and cause pressure or even rupture. You do not want your ears or your bowel to fill up and rupture. Okay. And the last one that I put up here is warfarin, long term anticoagulant. You don't want to give it before major surgeries unless it's reversed with vitamin K. So like if let's say you have vitamin K on hand, we're not normally carrying vitamin K, but anesthesia may have another thing you do not want to give it because again, it's a bleeding risk. Okay. Does this kind of help a little bit? There's so many more medications, but these are the ones that um, I tend to see a lot more on the CST exam. So if there's another one that you guys can think of, let me know. I'll try to find some similar drugs and break it down for you guys as well. Okay, so Chelsea has, and I don't want to say your name incorrectly, Miss Rivera, but I had a question where it asked to reverse the effects you use in medications, but I can't remember if it was on the quiz or the mock. I can try to check your quiz. Of course, I can't check your mock. I'll try to check your quiz. Do you remember which week was it? Week 5 or week 6? And then
I'm
I
not
can kind of
Sorry, I'm not too sure. I think it was week 5 or 4.
Like,
It said something about adversely effects of like hypothermia or malignant. I forgot, but I could go back and try to look for it. But it I did have questions about it because it does ask about some medications, but I will have to look back and look into it. I don't know if anyone else remembers or got that question by any chance.
well, if you guys can let me know, because if you're talking about malignant hypothermia, y'all know the drug of choice is going to be dantrolene, dantrolene, dantrolene. And that like sticks in my head, like anytime I think of malignant hypothermia. And one of the drugs that can bring on MH is succinylcholine, which of course is from anesthesia. And another question that may come up is like with malignant hypothermia, unfortunately, that's one of those that you don't know until the patient's affected, which really sucks unless they have a history, like family history, and then they'll be looked at a little bit more. But yeah, please let me know so I can kind of look that up for you guys and kind of break it down. Dredgeline, I'm not really sure. Oh, dantrolene.
Yeah.
Yes, Dantrolene, dantrolene. Yes, for malignant hypothermia. Malignant hypothermia. That's one I have seen questions on. So yes, Miss Nairine.
I don't know if you want me to say this now. I was reviewing the weekly quizzes for previous weeks and I found two questions that have wrong answers,
Oh, for
but
the quiz,
as
send them to me so
correct.
I can document them. Get the correct because I like to get the page numbers or document where. So when I change you guys' grades, they can look and say, okay, this is where she got it from. So just send me those questions, and just so you guys know, when one person tells me if there's a question that was wrong, I go back through everybody's. So that way, it's just easier than this person may say something, this person might say something. All it takes is one
Yes,
person, and then I'm going to go back
I'll
through
send it
everybody's.
to you. One of them is definitely wrong,
Okay.
but the other question is the answer choices. Two of them are the correct answers,
Okay. That's
and
easy.
it's
I can fix that.
confusing. It has
Okay.
to has like one correct answer choice. I'll
Okay.
send them.
Yes, please do. Please do. And be looking for when you send it, let me know which week because that's going to be the easiest, which week and the question, and then I will go back through everybody in your classes.
Yes.
So, best case scenario, you will see an update. Worst case, nothing changes. Okay, like if you
I
got the
have a
correct
screenshot.
answer, then of course your thing would be the same. But if you marked one that was correct and it marked wrong, it will go up. Does that make sense? Like I'm not going to change it for the worst. So,
Yeah.
just so you guys know.
Yes, thank you.
Thank you. So make sure you do that for me.
Yes.
Okay. So you guys will get this. So just keep that in mind. You guys know I'll put it underneath in the archive area so you'll have that as a reference. But I also wanted to kind of break it down as to how you may see it on the CST exam. Granted, again, full disclosure, we don't know the exact same questions, but I wanted to try to find some CST style and kind of like get the roll going or get the ball rolling. Okay. So here we have a question. And you'll notice that I'll have the answer there so that you can kind of see. Now, a surgeon is performing or preparing to inject a local anesthetic before performing a carpal tunnel release. Which of the following combinations would be contraindicated? So we look at the question, right? We know that it's A, lidocaine with epinephrine injected into the hand. But why? So we have the answer, we know the answer, but why? You can't put epi on digits. That's right. It can cause necrosis. So if you know the answer and you can put a visual image with it, it does help, right? Because we look at the other ones, lidocaine plain is for local anesthesia. Okay, that's cool. Marcaine for long-acting pain relief. But that's not a contraindication. That's something that we want, right? Lidocaine with bicarbonate to reduce stinging. Again, something that we want. So in this question, we have a couple ways to look at it. We know that three of these are positive, right? Right off the bat, they're positive. There's not going to be something that we wouldn't want. And then we look at when it's injected to the hand, now we have to think a little bit more. So then we have this visual image. Okay. And granted, you're not going to have visual images on your CST, but stop, take a breath. Remember, you can close your eyes and kind of think, what would happen if lidocaine was injected into the fingers, the hands, the digits? And then we start to think about necrosis, right? It starts to vasoconstrict and we lose blood vessels. And so now there's not enough blood going to the hands. Okay. I see a question. I'm going to go ahead and copy it and put it in my list so that I can kind of touch on it before we get out of here. Okay. All right. So I see your question. No, you're good. I see your question. I'm just going to copy it so that I don't forget it. All right. Okay. Question 2, we're talking about another contraindication. Which of the following medications could be contraindicated during surgery for a patient who has a known bleeding disorder? So again, we know the answer is A, but why? Why would we not want to give a patient heparin that's bleeding? Remember that heparin is an anticoagulant and would worse. That's right, Margarita. Yes, Chelsea. Yes, Alejandro. It's an anticoagulant. It's going to make the bleeding more. Okay. All right. So before we go to the next one, I wanted to answer the question because it kind of goes along, because then we're going to go into the oscillating saw. I know somebody wanted to see it in action. So the question is, I have a question. I've seen rhinoplasty and the surgeon use Lido with epilepsy or epinephrine, but he didn't inject it into the tip of the nose. It was more like inside of the nose canal. So just like your digits, your tip of your nose can vasoconstrict, and you can also have necrosis of the tip of the nose. Okay. There are certain medications that you have to be careful of. We had a patient who we were deployed. They were in Germany to save her life, life over limb. Of course, their medication is a little bit differently. The medication they gave her, basically, she came back with no hands and no feet and the tip of her nose, because what it did is the medication itself took all of the blood from the areas that, how do I say it? It concentrated on internal body organs. And so her fingers, her feet lost vascularity. Okay. If that makes sense. And she was young. Okay. Also keep in mind that the nasal mucosa, trying to make sure I don't miss any other questions, is highly vascular. So injecting here can cause, again, that vasoconstriction, and that's something that we don't want. Excellent question. Does that make sense as to why they didn't inject it into the actual nose and that cartilage, but inside? Okay, perfect. Okay, so these are excellent questions. Okay, now switching just a little bit, because the other question was about the oscillating bone saw. And I know how the question says it's side to side. And I kind of just wanted to show you exactly what it looks like. Now, it's actually more of a back and forth, but side to side is how the CST will ask it. So that's how we'll say it. So let's take a look at this oscillating bone saw, also the sagittal saw. All right. So did that kind of make sense how it's like zzz, like side to side? Okay. Technically back and forth, but side to side. Okay. All right. So there was another question. It says a bleeding disorder. How do I know if it's hemophilia or thrombophilia? Another really great question. So I want you to think of it this way. We look at bleeding disorders, okay? The tendency to kind of bleed, right? Most commonly, you look at hemophilia, but that's not the only ones. There's one, von Willebrand disease. There's a platelet disease versus vitamin K, okay? So here are some clues when you're kind of thinking about it. Uh, easy bruising, prolonged bleeding after like a minor cut or surgery, or spontaneous bleeding like joints that bleed or hemoarthritis. Okay, that's going to be more of, make sure you were saying, make sure I get it. Scrolling back up, hemophilia. Okay, you'll see that bruising, something that's bleeding more. That's not going to be thrombophilia because that's the tendency to clot. Hemophilia, it's bleeding. Thrombophilia, it's clotting. Okay, so examples would be someone that has a protein deficiency. Um, here's some clues for thrombophilia. Okay, if the patient has a history of DVTs or deep vein thrombosis, if the patient has had a stroke at a young age or recurrent miscarriages, hemophilia, bleeding, thrombophilia, blood clots, clotting. Does that make sense? You have a Roby saw that looks similar. Believe it or not, a lot of ortho instruments that we use are just like what you can get at like your local Lowe's or Home Depot, believe it or not, just cost more. Yes, I see a hand up.
Okay, I don't think my question was clear enough. What I meant was like that question with the heparin, the answer heparin, like when it said bleeding disorder, it didn't specify whether it was like excessive bleeding or
I see
clotting.
what you're saying. How will you know if the question is related to a patient profusely bleeding
Yeah,
or if it's the opposite where their blood is clotting?
yes.
Okay. So this is kind of tricky. You're going to, and I hate to do it this way, you're going to tend to, when they say a bleeding disorder, think of where um, the patient is unable to, because this is how I think of it when I think of bleeding disorder, they are not able to clot. Usually they'll tell you if they have a clotting disorder. They don't tell you if they're constantly bleeding, if that makes sense. So if you see a question and they're talking about a bleeding disorder, and I always hate to say assume, but in this case, you're going to assume that their body is not able to clot. When they say that the patient has a history of blood clots or deep vein thrombosis or strokes, that's when you would think of thrombophilia. And that is an excellent question. And thanks for clarifying, so that you kind of have an idea of this is a blood clot. Otherwise, think of it as bleeding,
Okay.
prolonged bleeding.
Okay,
Okay,
got it. Thank you.
you're welcome. You're welcome. Okay, let me make sure. Okay. The other question or the other thing that you guys talked about was ophthalmic instruments. And I believe we're going to be breaking that down a lot more next. I think that's a part of the next one, but I did put some stuff in here so that we can kind of get a little bit familiar with later. But just keep in mind that we're going to be breaking down specific eye instruments when we go over eye cases and all that, which is actually next week. So I just want to let you know that I still have it, but I'll be able to go into a little bit more detail as that's one of our subjects that we're going to kind of break down. Okay. Now, if there's any like certain eye cases, or if you haven't really done eyes much and there's something that you're just curious about, let me know so that I can kind of get that ready for us. All right. Today, this week, we are looking at plastic and reconstructive surgery. Okay. We look at what is it all about? Like, this is just our refresher, right? We know that it's to restore form and function after some type of trauma. Maybe there was a defect. We're going to look at grafts, flaps, scar revisions, cosmetics, and then kind of tie it in. Like, why are these questions that CST examiners put on tests, right? Like, what is their focus? Is it symmetry mainly, tissue handling, or even the cosmetic outcome? Okay, because we're putting ourselves in the individuals that are writing these tests. Okay, so right off the bat, we kind of just go through the basics when we look at the difference between a split thickness and a full thickness. Did you know that when we are taking a split thickness, we are really just getting the epidermis, okay? But when we want a full thickness, we're going to go all the way to almost the hypo, but dermis and the epidermis, okay? With our flaps, we have rotational, advancement, and free flaps. And of course, with scar revisions, we're just trying to cosmetically improve the look. Okay. Again, you guys know I like to do my little charts. You should see my Excel worksheet. It's probably tired of me. I don't care. So for here, I got the features, tissue blood supply, skin graft, must be revascularized, flaps, the different types, split thickness, full thickness, local rotational, um, and then common CST questions that they kind of tie or throw at you. When to use a full thickness graft, and then how to identify flap types and facial repairs. So this is where we're gonna kind of hone in on, okay, to kind of break this down. The other thing that we're going to look at is the type of instruments that we're going to use. So if you've ever worked with a plastic surgeon, you know that a lot of them take a long time to close, a very long time to close, because they really want to approximate the skin inches to make it look like they were not even there. I actually had a general surgeon who takes a long time to close, but he's been a surgeon forever, but his incisions are so beautiful. Like, you would think he's a plastic surgeon because of how much attention to detail he puts into it. So we look at our scissors, we look at the types that we use, like Adsons with T for Adson Browns. We're going to use our scissors for ophthalmology more, and tenotomy scissors for plastic and reconstruction surgeries. So that's another kind of thing that we kind of look at, like what instruments would be more appropriate and why. Okay. Retractors that we'll use, we may use a small malleable depending on what we're doing, or skin hooks. And the other thing that the CST will do as a trigger is to try to have you, as you guys can see my little notes, match instruments to like different parts. Okay. Here's an example. So we have a surgeon. Okay. They are preparing a pressure ulcer using a rotational skin flap. Which of the following principles is most important to preserve tissue viability? So we have designing the flap with a wide base to ensure adequate blood supply, making the flap as thin as possible to improve cosmetic appearance, placing the incision perpendicular to natural skin tension lines, or including only the epidermal layer to limit donor site morbidity. And when we look at this, we want to understand blood supply. So you guys are on point. We look at the geometry of flaps. Wide base equals vascular preservation. A lot of these other things are awesome, but we want adequate blood supply. We look at our clinical reasoning plus the anatomical relevance. Vascular preservation. So of the four, A is going to be the one that ensures adequate blood supply. So good job. Good job. We're not done. Getting back to that. full thickness. Now, the graft is taking post-articularly area to reconstruct a nasal defect following Moss surgery. Which of the following best explains why full thickness graft might be chosen over a split thickness graft in this scenario? So, I have an image for you. So you can kind of see exactly what's going on. Now, keep in mind, I know there's no images on the CST exam, but this is where you take your deep breath and then you kind of picture the particular case. Okay. Here, we look at the full thickness. Grafts are preferred in cosmetic areas for better aesthetic results. So we want to base it on cosmetic outcomes because in this particular preferred, right? This particular case, we're just trying to give the patient some type of normalcy. So we're trying to, how do I say it properly so that it kind of sticks with it for you guys? We want the patient to feel as normal as possible, right? Like a better match. So it's going to be, out of all of these, superior color and texture match for facial reconstruction. Because in this particular instance, we are trying to do more cosmetic. It's not for vascularization or anything else, but um, like nothing was there. So we want to kind of provide a texture match, especially when harvested from different areas. So the area we're talking about is behind the ear, which has similar skin to the nasal region. So if you look behind your ears, I just said look behind your ears. If you could take a picture and look behind your ear, you'll notice that it'll match your nose or your nasal region a little bit better. And so it gives for a better cosmetic appearance. There we go. Cosmetic appearance for the particular, in this particular instance. Okay. I got excited. I flipped it. Hold on. Let me just make sure you guys can see again. So the back of the ear, this, you 9 times out of 10 came from the back of the ear so that when it heals, it'll look more cosmetically appealing for the patient. Okay. All right. During a cosmetic blepharoplasty, the CST prepares instruments for closure. The surgeon emphasizes alignment of skin edges with minimal tension. Okay. What is the primary reason for this approach in cosmetic procedures? So we have to allow quicker epithelialization and reduce infection, prevent scar hypertrophy, and preserve natural contours, to ensure tight wound closure and reduce fluid accumulation, or to support the tarsal plate and prevent ectrodropin. Now, first thing we look at is what is a blepharoplasty for those who have not had the opportunity to do many plastic procedures. So someone explain what that case is from the beginning. Right. Eyelid surgery. Okay. The primary goal is not to close a wound or anything like that. It is primarily aesthetic. Okay. So we're trying to avoid visible or raised scarring. Okay. So we're just trying to fix the eyelid. Now, the other options you had A, which we know is incorrect, C was incorrect, and D. Okay, so we are really just trying to prevent scar because they're going in there to get it fixed. So they don't want to go in to have a scar where there may have been excess skin, right? Because that really would defeat the purpose. Okay, so our focus is prioritization of aesthetic outcomes in surgical decision making. Okay, so one of the things that, for me, a clue, this is cosmetic blepharoplasty. So when I hear that, I'm automatically thinking, okay, when we're talking about cosmetic, what is going to be one thing above the rest that we want to happen. We want to prevent a scar. Okay. We want to have the skin edges approximated appropriately. Okay. So, okay. Minimize tension, better cosmetic outcome, and scar formation. Okay. So we have a 3-month-old infant. They're scheduled for a unilateral cleft repair using a Millard rotation advanced technique. So the key is the actual case. Unilateral cleft lip repair. Now, the procedure is being performed to improve feeding, speech, development, and facial symmetry. We look at a couple of perioperative considerations. Okay. We have the infant must meet the rule of tens, at least 10 weeks old, 10 pounds in weight, and a hemoglobin of 10. Now, the infant's airway concerns, there's going to be special positioning, and of course, we're going to be monitoring some things. The goals, we want to restore continuity, create some type of symmetrical nasal and lip contour, and of course, this is cosmetic, kind of. So we want to minimize scar visibility. For our prep, we're going to use a gentle anesthetic on the face. We have an infant here, right? And we're always going to protect the eyes during draping. But some other things we think about with trays. Plastic surgery sets, they're going to have fine tips. The instruments are going to be used, as you guys can see, for precision. I wanted to grab a Minnesota so you can kind of see what it is if you haven't used it before. And we do use some microsurgical instruments. So a lot of Castroviejos, Webster's, tenotomies. Okay. Do not get Castroviejo needle drivers confused with standard ones. Okay. Your Castroviejo needle drivers are going to look like a needle driver just on a Castroviejo versus your Castroviejo scissors and other instruments. Okay. We have to be able to distinguish between locking versus spring action mechanism as well. So these lock. I don't know if you guys can see right there, they have little locking mechanisms, but some don't. So when I'm in eye cases and I have Castros that do not lock, one of the things that I do is I'll grab the back of a syringe tip, put my suture on, close it, stick it into my syringe tip, and then when the surgeon needs it, I can hand it to them without losing those tiny needles. Okay, just a little tip. All right, now the correct order. They mark, then they dissect and mobilize. They reapproximate the muscle skin layers, then they close, and then they apply Steri-Strips. Okay, that is the correct sequence. Wait, I think I told you guys wrong. What I want you guys to do is look at this and figure it out. But we will do that later because I was just like, wait, I have the right sequence on my end. So what I'm going to do is send that to you guys so that you can kind of put it into place. Okay. The other thing that I wanted to kind of go over is some misconceptions. Cliff lip repair is only cosmetic. If you notice, I was like, kind of not really. Why? Because it's both functional and aesthetic. You got to keep in mind that a lot of times these infants, they're not able to drink properly, eat properly, and of course, they're not able to speak well. They may have delayed, delay. They may be delayed because of it. So, of course, we are going to give it to them for cosmetic reasons, but we're also fixing their speech. We're helping improve oral competency and support the mid-face development because these babies are still growing. General instruments are acceptable for all facial surgeries. Again, that's a misconception. A lot of times we want to use the finer instruments. Okay. We want to have micro surgical instruments available because it will help to reduce tissue trauma when we're using these large instruments on these tiny babies. And we want it to be precise for pediatric procedures. Okay. So we look at some of the differences on what instruments would you set aside if this were a cliff palate repair instead of a cleft lip. Now, of course, I was trying to find an image that just had the lip, but I found one that had the palate and the lip. So just pretend like the palate part was already intact and it was just the lip. So you have a cleft palate versus a cleft lip. Now, keep in mind that you're not typically going to need skin hooks or facial skin retractors for a palate repair. It's not needed due to the intraoral approach, like it's already open. We have visualization, the surgeon has visualization, but fine facial suturing instruments like Webster needle driver or delicate tissue forceps are going to be used more often for visible external skin closure and your lip repairs. Now, keep in mind that mouth gags or Dingman retractors are going to be very important for oral cavity access. We may use a suction that has a lumen like a Fraser or a Yankar because there's going to be secretions in the mouth. I don't know if many of you have had the opportunity to do a cleft lip or a cleft palate. We also tend to use needle tip bovies and bipolar forceps for hemostasis, especially around the oral mucosa. Okay. With this, I want you to think about what the CST must prepare. Like, what do we have to prepare differently when visibility is limited or when mucosa rather than skin is involved? So think about a lip where it's pretty much superficial. You may have to lift it up versus what we'd have to use with an actual palate inside of our mouth. Okay. And then how would the setup differ if this was a scar revision in an adult versus a child? Like a lot of stuff's going to be the same, right? But some things are going to be slightly different. I want you to think about the patient's age, skin thickness, anesthetic priorities. You have a 10-weeker versus a 30-year-old, right? Would the instruments be completely the same? Right. The size, healing process. Exactly. Sometimes revisions do include Z-plasties. So depending on the size, I have done patients as young as a couple minutes old, and patients that were, 80s, and older. Both of the patients in these two instances, of course, the skin was very delicate and different things, but for an older patient, you will still tend to use the longer instruments versus on the infant, for example, we use a lot more smaller, delicate, fine instruments. Not saying that you can't on an adult, but the size did play a huge, huge part. Okay. Sutures may be finer, non-absorbable sutures, because we want minimal scarring in visible areas. Like the patient's coming for a scar revision, right? So they don't want to leave with a larger scar. Okay. Keep in mind that some scar revisions are going to focus on aesthetic subunits of the face. All right. So we're going to have to anticipate just organizing, for layer closures. All right. Okay. Let's see. Let's work this one out. Hold on. Actually, it's actually time for our break. So you guys go ahead and take 10 minutes and then we'll come back with head and neck. Okay, so be back in 10. All right. Where is my camera not turning back on? Trying to get my camera turned back. Okay, good. I was like trying to get my camera turned back on. I'm like, what is going on? Okay. So we start talking about head and neck surgery. Okay. We look at CST critical concepts, common surgeries that you may see on the CST: thyroidectomies, paroidectomy, neck dissection, and tracheostomy. So a lot of the key risks that we look at: facial nerves, parotid, we look at your thyroid. And then with these cases, we're always looking at airway management. Okay. So they'll ask you questions about like different retractors, like the green loops or self-retainers, delicate tissues, and then suction and hemostasis prep, especially when we talk about tight spaces. Okay. Again, here is a little chart so that you can compare thyroidectomy versus tracheostomies. Okay, ectomy, where you're cutting or dissecting, and ostomy, where you're creating an opening. So again, you know, granted, you don't have the image in front of you, right? But it's kind of good to kind of have an idea. So for your thyroid, you look at the incision site versus a tracheostomy. You look at key structures at risk, as well as instruments, and then what they focus on the CST. For thyroidectomies, we're looking at controlling bleeding, hemostasis, nerve protection. For tracheostomies, this is going to be an emergency case, most likely. Suction readiness. Okay. Um, right. You look at the difference between ectomy and ostomy, take it back to basics. Okay. That's really what you're doing. And if you look at where your trachea is, you're creating a hole. You're looking at where your thyroid is, you're removing. So I love how Christopher said that. And that's correct. Ectomy versus ostomy, going back to basics. Okay. We look at which case would need a nerve monitor and why. Okay. Which case would need it. So these are going to be some of the things you're thinking about. Now, we look at common instruments. Okay. METs, tonsil clamps, your green loop retractor. I wanted to make sure that you guys seen it because, again, I know that not everybody has been exposed to every case. This provides general retraction in a thyroidectomy, not a tracheostomy, a thyroidectomy. So just kind of keep that in mind. So we have a 45-year-old female. They're scheduled for a total thyroidectomy. So going back to how Christopher said, ectomy and ostomy. So think about what we're doing. Due to a multimodular goiter. So those are going to be, those growths that you see a lot of times in individuals is usually kind of protruding from one side or sometimes right in the middle. And the patient's now having difficulty swallowing, and they're losing their voice. So they're becoming hoarse. The surgeon will perform a cervical incision to expose the thyroid and remove both lobes with attention to preserving the recurrent laryngeal nerve. So then you think about that green loop nerve retractor, right? And the parathyroid glands. So we have some considerations that we have to kind of look at. Okay. They are going to be worried about the vocal cords. They got to check it. Patients complaining, they're starting to sound a little bit hoarse. Okay. There's hoarseness that is present. We're going to be doing nerve monitoring. We're also going to look at calcium management because of the parathyroid risk. So, what would be some of the surgical goals? Well, we're going to completely remove the thyroid gland. We got to make sure we are not causing additional injuries, right? And with anything, we're minimizing bleeding in a vascular area. The patient is most likely going to be supine with neck extended in the sniffing position, kind of like that, right? Shoulder rolls may be placed because we want to enhance the exposure. So they're more like, kind of like sitting up like that. Basic head and neck set. The retractors that you may use, you may have a Wheatlander, but more importantly, that green loop retractor for exposure. Mets, Atsons, mosquitoes, precise vessel sealing, so you may have the harmonic scalpel. A ligature is usually preferred, but again, it's going to be where the surgeon was trained. You could bring the neck. So the question is bringing the neck forward more, could be, but you definitely want the sniffing. I always think of it like their head because you want exposure to that area a lot more. And so that's why we'll normally put a roll behind them just to kind of give us just more exposure. Now, with the monitoring, that can be handled by anesthesia, but we will sometimes assist in connecting it. It just depends. Hemoclips for ligation. And you don't want to confuse head and neck retractors. So green loop retractors are specifically designed to gently retract thyroid and like the different muscles. Okay. Got some more little tips to kind of help you guys. So we look at the procedure in order of sequence. This is not the procedure order in sequence, okay? So what I'm going to do is for this one and the other procedure, I'm going to provide you guys with just to see, can you put them in order? I'm going to show you, of course. All right, so this is the actual procedure, how it's made from start to finish, especially if you have never done these cases. Okay, so I'm going to provide you with the procedure list in Moodle. All right, but there are also some concepts, there are misconceptions that is really important to kind of make sure. Our role does not end with setup. Okay, we may be helping with nerve monitoring. We may have to have extra just agents to control bleeding. Sutures, make sure you have them. Now, the parathyroid glands are removed with the thyroid. Now, if we can save them, the surgeon will try, of course, to save them because they want to avoid post-op hypoglycemia. So it's important for us to just kind of have, like, we know that when we do these cases, ideally, we want to try to save as much as we can. Sometimes you just can't, okay? But you would always have extra stuff ready, extra clips, extra sutures, stuff that the surgeon would normally have. You would just have extra just in case you need them. Okay. So let's work it out together. Which instrument would you remove or replace if there was a tracheostomy instead of a thyroidectomy? Okay. So keep in mind, you're going to have up, keep in mind, we're going to track tracheostomy. Someone put up a harmonic scalpel. They put up fine bipolar cautery. They put up a regular scalpel, 15 blade or 10 blade, hemostats, mets and bombs, and some Atsons with teeth and DeBakey's. We are doing a straightforward tracheostomy. So for me, I would be like, I'm gonna put this harmonic scalpel to the side, and you can put the fine bipolar cautery to the side. Not gonna need that, but keep it available because you never know. But what I would add is maybe a dilator because we're gonna be dilating the trachea so that we could put in the trach. We would get the tracheostomy tube set and the dilators again for that trach. For the tracheostomy, the key is emergency preparedness. Yes. And when we do the thyroid, then you would look at your thyroid instruments. For my thyroid, I'm going to, be looking at the McCab. I may be looking at removing, actually, I wouldn't remove anything, but I would be grabbing back my harmonic. I would be grabbing back my fine bipolar cautery. I would make sure I have my green loop retractor. Now, we look at how would the instrumentation approach differ if this was a parathyroid. Okay. So you guys know I'm going to try to find images for you. Okay. So disclaimer, but you guys have been in the operating room, so it's a little bit different. So we look at the incision. Okay. We have the modified Blair, or we may even have the facelift incision around the ear and jawline, kind of like how you see. We will definitely need a nerve simulator, or because we have to identify facial nerves. We, the team, right? We're probably going to have microsurgical instruments, um, sin or skin rakes for superficial dissection. Now, keep in mind that the parathyroid involves dissection around the facial nerve trunk. So the surgeon is going to be very meticulous. They're going to want to make sure they have some type of identifying instruments to make sure that they're where they're supposed to be. That's going to be really important. We've got to be aware of our instrument needs, the anatomy, kind of what exposure will the surgeon be expecting. Granted, I know I keep saying, I know there's no images on that CST exam, but if you have been in the case and now that you're seeing it, hopefully you'll be able to kind of recall it when it comes through. Okay. Yes, some surgeons will use sutures, most definitely. Again, it's going to be where they're trained. So some surgeons were trained with, they mark everything with sutures. Some do not. Okay. Lone Star retractors, most definitely. If you have not seen Lone Star, let's see if I can get an image for you guys really quick of Lone Star. Not sure if I'll be able to pull it up. If not, because I know not everybody has seen them, I can try to describe it. Okay, let me we're just gonna go here and do it. There we go. So Lone Star, okay? You have fish hooks. I don't even know if that's the right term, but I always call them the fish hooks. I always hand up my fish hooks on a hemostat. That's just how I was trained. And the Lone Star, if I could see, I'll try to find an image where it's in action for you guys so you can kind of see. But the Lone Star, I've used them in urology. I've used the Lone Star in urology cases as well. Okay. Yes, always cut. So cat said I always cut my telfa into sections because sometimes they have to go in and get multiple biopsies until they get the correct confirmed tissue. That is a, I want to say boss move, because that's one of the things that I do as well, where especially if I don't know how many biopsies we're gonna need, I make sure I have enough. So yes, good job. All right. Um, another Another section from before was on plastics. So now we kind of focus back on some of the questions you guys had from mock 2. Okay. So, of course, this week we focus just a little bit more on plastic surgery instruments. All right. So, some of these you kind of already seen, but who can name this instrument that's in front of me? Yes. Okay. Yes, dermatome. And hold on. Christopher just hooked us up. He found an image for us. So give me a second. Boom. There you go. The Lone Star in action. So thank you, Christopher. So you guys can kind of see it and how you see the fish hooks. Okay. How that's done. And this is especially for those who haven't had the opportunity. So you guys make sure to give Christopher a thank you. So that was awesome. Thank you. Yes, this is dermatome. Okay. Used in skin grafting, large surface areas, such as like a patient that was burned. Okay. Let's see if you guys can name this one. So if the other one's the dermatome, and I kind of showed you guys these before, what instrument is this one? I'll give you a hint. We've already harvested the skin. Yes, it is the derma mesher. Okay, this is where the surgeon is going to increase the coverage. Okay, so make it a little bit easy for you, right? What about this one? What do you think this type of scissors are for? So keep in mind, we are in plastics. So I'll go ahead and give it to you guys. These are the K facelift scissors. Now, these have very sharp dissection with a fine control. So they're more for contouring around facial structures. Okay. These are K facelift. They are specifically designed for facial procedures. Okay. So if you ever have a question, what scissors would be optimal control for delicate tissues like dissection during cosmetic facial surgeries? Now, we know the CST exams are not going to be that cut and dry, right? But you go back to the basics, okay? What about this one? Do you guys know what this one is? Yes, these are in the book. These are in the book. Yes. So the question is, are these in the book? Yes, they're in the book. And they're all in plastic. So all of these instruments up to this part are plastics. They're in the plastic section. But don't worry, because you will get the plastics Quizlet. It kind of, right? It is a handheld. It's not necessarily a retractor. This is your Blair elevator. So I was trying to find instruments that you guys might not see that much. So this elevates soft tissue, particularly around skin flaps. So it's commonly used in facelifts, paroidectomies, and other types of head and neck surgeries. Okay, so this is ideal for separating skin from underlying tissues in a controlled, like sweeping motion. Okay, so it is a Blair elevator. Blair elevator. Here's another one. I'll give you a hint. This is also used for harvesting split thickness. So remember, this is just going to be the epidermis, not the epidermis and the dermis, right? Not the whole thing. This is for split thickness skin grafts to be done manually. So what would this be? It is a knife, usually for burn treatments or patients that have burns and reconstruction. It's actually, yeah, oh, that's perfect. That's okay. This one is called the hand. I know. So it has a basic name, hand grafting knife. So we use this to manually, and it's because sometimes they don't even use like for split thickness, just depends, but some surgeons were trained on the hand grafting knife. So a lot of times they just say grafting knife, and that's what they mean. This is what you would give them. Okay. Now, let's do a scenario based on that same instrument we just did. Okay. During a reconstructive procedure following facial burn debridement, hint, hint, facial burn debridement, the surgical team prepares to harvest a split thickness skin graft. So automatically know the dermatome is out because that's for full thickness, right? From the patient's thigh. The surgeon requests an instrument that allows for manual control or cover over the thickness and shape of the graft. The power dermatome is unavailable due to, it is just not working. Yes. So what I did is grab that same instrument you guys just saw and put it in a way that the CST may ask it. Again, I know that you're not going to be able to see images, but I'm just trying to help with the scenario. Okay. Here's another one. This one is the Tabit's retractor. I went ahead and named it because I'm not sure if you guys have seen it or used it. This is designed for precise soft tissue retraction. This one's often used in facial anesthetic surgery or procedures where exposure to like underlining exposure or underlining structures is required without trying to excessively traumatize that tissue. So we think about surgeries that require long, narrow retractors to gently hold tissue aside without causing a lot of bruising or damage. Okay. So here we go. A surgeon is performing a mid-face lift. Keep in mind, we're using the same instrument we just saw. So what we're doing is seeing how you would see it in a CST scenario question. A surgeon is performing a mid-facelift as part of a facial anesthetic reconstruction. During the approach, the assistant is asked to gently retract the soft tissue to allow for precise dissection around the zygomatic arch without causing trauma or bruising to surrounding structures. So you see how they could potentially ask it. For here, the key words are precise dissection without causing trauma or bruising. Okay, so that's going to be one of the things you're like, that's going to be the Tabit's retractor. So if this question happens to come up, now you'll be able to see it. And the question that I saw, this is it's a different one. I'll have to think of the name, but it is different. So I think I've seen it, a breast reduction. So it's a different one. I'll have to write that down and make sure you guys, so you guys can kind of see it once we get to that particular section. But it is different. They're going to use, I'm going to write it down because then I'll go off on a tangent. All right. So just keep that in mind. This is how you would see it if it was going to be on a CST question. The funny thing is, isn't it like a color blue? So hold on. Okay, A. The funny thing is Tebbets, the actual retractor, Dr. John Tebbets, because I like to do extra research. He was known for innovations in breast augmentation. So just keep that in mind. But I will kind of break all that down when we get to that section. You guys are good. I love that. All right. Now, who can relate to this? So the doctor's asking for an instrument we rarely use. This is our doctor going through our stuff, all in our field. Like, what are we doing? All right. So I kind of wanted to kind of break up the monotony a little bit. Yes. So you have done a lot of, so I'm asking Kat, has she done a lot of plastic procedures? To create a cave and retracting has a built-in light that helps with visualization. Yes. I like that. And then they changed their mind. So yeah, you're searching. I'm going through all the questions because yeah, that definitely does happen. So one of the other topics for our mock CST that we could work on is asepsis and sterilization. And I grabbed a asepsis, kind of like a cheat sheet for you guys to kind of use, kind of break things down. Okay, because this is a refresher. We look at the sterilization method. Okay. And one of the things on the CST exam is when they're asking, ETO versus dry heat versus flash versus high level disinfection, right? And we try to think back to, oh my goodness, which one do we not use it for? Because that's going to help with process elimination versus which ones we do. So I created this one for you guys. For those in 600, go ahead and take your screenshot. For those in 700, I got you. So it's going to be in your Moodle week 7. Okay. But utilize this just as another way to kind of break down stuff that you don't know. Still go back and, go to the certain chapters. I think it's chapter 10 in the Fuller's book where we break down decontamination and sterilization. But this way you can easily kind of just reference it and it'll help break it down as a little refresher. Okay. Especially when it comes to plastic scopes and delicate instruments. Also, here's some tips. Okay. Steam is going to be the go-to method unless the item is heat or moisture sensitive. Okay. ETO, gentle, heat sensitive. So I want you to think of like plastic surgical procedures or plastic instruments and scopes. They are going to require longer aeration. Stare at, fast, clean, not for liquids or long lumens. Remember, lumen is just the space, the hole that can go through. Dry heat, specialty, powders and oils. Okay. Flash, we only flash during emergencies. It's not acceptable for implants unless explicitly stated. Okay. Think about every time you needed a flash instrument. Think about even when it's with a lumen, what do we do? And then high level disinfection, not sterilization, used mainly for scopes. Okay, so your colonoscopes, your EGD scopes, things like that. All right. Again, plastic, no heat equal ETO. Drop instruments during surgery. I got to get it fast. Powders or oils, dry heat. Scopes, not requiring sterility, high level disinfection. Lumens need to be sterilized, flush dry, steam or ETO. Okay, remember that's the very first part. All right. Okay, any questions? Okay, so far nothing. Okay. So now, do you think you can identify these items? I'll give you guys a couple minutes to see how well or how comfortable you feel being able to identify, and then I'll come back and see how well, and this is only honor system, y'all. So give you guys a couple minutes, see if you can match them from your recall, and then I'll reveal, and then you guys can kind of tell me you got them all, you're iffy. Okay, let's give you guys about a minute. I think that's all you need, about a minute. Okay, it's been about a minute. All right, again, the honor system. How did you do? How did you guys do? Feel comfortable? Awesome. Now, before that, I saw a question. I thought I saw a question. Slay. I like that. Doctor-specific items are one type of item in the whole hospital for flashing. I think you're asking which one it's going to be based on the facility. So it's going to be each facility may be a little bit different. So just kind of keep that in mind. Okay. All right. Good job. I'm like looking pretty good. All right. Now, again, I will be presenting you guys with your Quizlet, um, so that you will, just be a little bit more comfortable with all of the item subjects for this evening. Okay. And then of course, 600, I'll make sure that Miss Shrooms get you guys it so you guys can have it as well. Our stress management tip number 7. Take a look at that image, right? What do you really see? Keep in mind, nutrition is big. I know that it sounds like, how is this a tip? But hear me out. What you eat does have a direct impact on your brain, your mood, and stress levels. Whole foods like fruits, vegetables, nuts, whole grains, I'm not a nutritionist, just so you guys know, but can boost your energy and support like just mental clarity, helping you stay hydrated. It is just as important. Sometimes fatigue is just thirst in disguise. So this week's challenge, I want you guys to try, not a requirement, but I want you guys to try adding just one more serving of a colorful fruit or vegetable each day. Your mind and body will actually thank you. I feel like a commercial, but I want you to also reflect on what one food swap you can make this week to actually boost your energy. For example, swapping soda for, let's say, sparkling water with a lemon, or chips for carrot sticks with hummus, or ranch dressing, or your favorite, and see how you feel by the end of the week. Okay. Aqua frescas. What takeaways do you guys have? I love horchata. I gotta focus. I like Jamaica too. What? It's okay. What takeaways do you guys have for today? Like, was there anything that you didn't really notice, or something that you're like, aha, like an aha moment? I am curious as to how you feel about today's live session. Because keep in mind, we have what, 8, 9, 10, 11, 4 more live sessions. And I want to make sure that I am hitting on things that you want to really improve on and help, or you feel it will help you for our next mock and ultimately the real CST. Thank you, Noreen. I haven't seen before and it's making me feel a little bit more good. If you feel right to it and you answered questions I had from last meeting. Okay, good. Most of the plastic instruments are new to me, so that was useful. Awesome. Awesome. Let me see. So I can kind of give you guys an idea about next week, because I think we have more specifics on next week. Next week is ortho, which y'all know is my favorite, and ophthalmic. So next week we're really diving into ortho, ophthalmic, and intraoperative procedures. We're still going to do some instrumentation, identification, and of course stress management number 8. Getting explanation of why the instruments was used was helpful. Awesome. There are always new information in each meeting. With that, were there any questions from this week's or last week's knowledge check or quiz that you need a breakdown? If you don't know right now, that's okay, but try to get it to me preferably Friday so I can kind of break it down, do my research, and have it ready so I can start working on your PowerPoint for next week. Okay. Topics or materials we will see. I can try to ask her. So the question is, for the last mock, are you able to ask Miss Shrooms what certain, I can always ask. Um, but she may not even know. So, because it's all random, but I will go ahead and copy that and write it so that at least, either she'll know, or we're going to keep doing what we're doing. Okay. But I will definitely already have that copied and pasted in my little notes that I have on my screen. Any other questions? Well, we covered a lot this evening. We started off looking at week 6 questions that you guys had, lumens. I still don't know what the Furuka retractor, but I found the Furuka test and at least the Finochetti retractor, which is a rib approximator or rib spreader. Depends on where you were trained, what you say. I was taught it was the rib approximator, but part of the book, the rib spreader, right? We looked at different facial and head and neck procedures. We distinguish between thyroidectomy and tracheostomy, as well as instrumentation. Remember, thyroidectomy is removal, so there's going to be different nerves and things that we're going to be protecting. Thus, you'll need the green loop retractor versus a tracheostomy, where it's more of an emergency. We need the patient to be able to breathe. So the instrumentation is going to be slightly different, right? And the thyroidectomy is going to be more of a sterile case. Tracheostomy is still sterile, but we're talking about airway, which is going to still, you're going to be working clean as well. We broke down instrumentation that you'll see a lot in plastic and reconstructive. Remember those K facelift scissors, not to get them confused with churches or tenotomies or even your medicine bombs, because they're going to be specific for facelift and reconstruction. We looked at why we would have certain instruments for flaps. We looked at the types of grafts from split thickness, full thickness. You guys even learned what the handheld facelift knife is. It does a lot of the same thing that dermatone does, right? We know that the dermameasure is going to be used because we want the patient to have more surface for revascularization and better blood supply from the graft. It is always humbling to have you guys here on Tuesday. Keep in mind that if you do have anything, I don't think you have any classes on Monday, right? Like this is your only class, which is on Tuesday. Okay, so I was going to remind you of the holiday, but we will be here no matter what. You guys, with that, if there's anything that comes up, especially with the quizzes, knowledge checks, you guys reach out as soon as possible so that I have a little bit of time to kind of do my research and make sure I have all the information that and pictures that I can to just help you guys bring it all together. Why? Because the finish line is right there. Okay, so keep pushing, keep moving. On that note, we're going to get out of here just a little bit early. Have a wonderful rest of your evening. Have a wonderful, safe weekend. And I look forward to seeing everybody for next week, where we're going to be talking about eyes and my favorite ortho. Good night, everybody.